So welcome everybody to our first ever skin cancer event. I think we need to give ourselves not skin cancer, Skin Pathway Board event. Give ourselves a big clap. Well done everybody for coming. Woo! Energy in the room. My name's Claire Rourke. I'm the Managing Director of the Cancer Alliance. I'm going to open the session and just give you a bit of a summary around the national picture for skin across the UK. But being our first event, the most important thing, or the thing that you need to get out of it, apart from the little freebie sweets and your nice coffees, and away from the daily job of what you all do, is to network, have the conversations with everybody. We're all on Teams calls, a lot of us, so to see people in the flesh is really nice, and to have those conversations. So it's really important that you all have that opportunity to network, and there will be plenty of opportunity to have conversations and network. We've got a large clinical focus, as you would expect, on the event today, looking across the whole pathway, but also pathology, surgery, oncology, across that whole pathway, with the patient's voice being pivotal to that. We want to talk about the challenges. We want to talk about what's not working well, what we need to do better, because we've got to make those improvements that we need in our skin pathway. So we're going to talk about that. But the most important bit about that is the innovations that a lot of you are driving across the system here in Greater Manchester to make those improvements. I need that thing. We want to make sure that you all walk away today with something that of value. So you've took your day out. We've spent a lot of time organising these events, so making sure that there's something of value for you to take away. A big thanks to Steph and to Jane and to the Cancer Academy team for pulling this together and getting you all in the room today. So that's really good. Now, some T's and C's. I don't think there's going to be a fire alarm, so I'm working that there's assumption that there won't be. Apparently there's a rugby team or some people over there, so I think we spotted some rugby players, so there might be some nice people walking around. That's nice. And there's Wi-Fi to connect to, water, coffee, and if you need to get up and out, please just get up and out. I'm not going to be that comedian at the front that shouts out the people that move. And please do come and sit at the front if you need to. So, my session is going to talk about national cancer priorities and the roles of the Cancer Alliance. Does everyone in the room know what a Cancer Alliance is? Put your hand up if you know what a Cancer Alliance is. Not everybody, that's good, because then you won't be bored in this session. You'll learn something, that's good. As I've just said at the start, my name's Claire Rourke. I am the Managing Director of the Cancer Alliance here for Greater Manchester. There's 19 plus Cancer Alliances across the UK. I've worked in cancer services most of my NHS career, 20 plus years, mainly at the Christie as an oncology nurse, and there's some of the nurses I work with in the room here today at the Christie. Started as a baby nurse, then went into the dark side of management, and quite liked it, and have stayed in kind of management roles since. I work on a lot of cross-cutting committees across the UK, supporting a lot of charities and other work as well. So I'm cancer through and through. I'm really passionate about improving cancer services, and it's a huge privilege to lead this Cancer Alliance and do the role that I do. So why are we here? What do we get out of bed for in the morning as a Cancer Alliance, and what is a Cancer Alliance? Because a few of you didn't put your hand up. So we are brokers in the system for cancer, and when I mean brokers, we're not biased to any provider, any primary care, any locality. We're representing the whole system in Greater Manchester. So we're here as a team, and there's 60 plus of us in the Cancer Alliance team now, of clinicians, managers, people from across all sectors, people who've never worked in the NHS before, work in the Cancer Alliance to make improvements across the whole pathway, right from the beginning through to the end, from palliative and end-of-life care. So it's supporting the whole of the cancer pathway. I'll come on to some of the governance, but we work on behalf of the ICB, which is the NHS Greater Manchester, but we're accountable to NHS England, so we're employed by NHS England to drive the improvements in cancer care. The critical thing is around early diagnosis, which I don't need to tell anybody in the room about. And I know recently the King's been diagnosed with cancer, and everybody's very thankful that his cancer, whatever it is, none of us know yet, was diagnosed very early. And that is a really important message to get out. And it's not just for the privileged, that's early diagnosis for everyone. And the critical thing for us as a Cancer Alliance is to make sure that it's early diagnosis for everyone across all our communities. And invariably, those of greatest need. So the ambition is 75%. We're not there yet at stage 1 and stage 2. Many of you know that a diagnosis of stage 3 and 4, it's incredibly difficult to manage that cancer and improve the survival and outcome and actually the quality of life of that cancer patient. So early diagnosis is critical and key. And when I started in oncology, survival rates were really good, but we're nowhere near. We made some significant improvements, radically changing how we give treatment, all of these fantastic immunotherapy treatments that we give, and patients are living longer, but we want them to live well longer. And that equates to nearly 3,000 patients in Greater Manchester. So how are we doing on our early diagnosis figures at the moment? We're about 56-57% here in Greater Manchester, and the average across the UK is 58%. So you can see how far we've got to get to the 75% by 2028. But Ali and the team, who's at the back, Ali Jones and the early diagnosis team, and many of you who work in primary care are doing some important work to drive forward that early diagnosis. And as I've said, that's critical. How we're doing on our skin. So this is melanoma figures here. In Greater Manchester, it's 94 against the 94 average. That sounds really good, and it is. But when we had our breast cancer event, we had a similar stat and a similar figure. And Claire Garnsey, our clinical lead for breast, that isn't 93% across the whole of Greater Manchester. So where you live dictates your early diagnosis and your survival. So we've still got that inequality of access and the health inequalities that we recognise in our communities. So we need to make sure that 93% is across the whole of Greater Manchester. And what is this long-term plan that we're held accountable to deliver on behalf of yourselves and on behalf of the system in Greater Manchester? Well, it's a plan in its totality to improve those early diagnosis figures and improve survival for cancer patients. But the thing that we do as a Cancer Alliance and that I'm passionate about is about listening to you, listening to clinicians, listening to nurses, listening to the ward clerks, listening to people who are in cancer systems who can tell us how to make things better. We don't need anybody to tell us how to make improvements in cancer services. Everybody in the room here knows how we can make improvements to skin services across the system. And we can only do that if we collaborate and integrate, and that's what we've been doing. I talked about us being brokers at the start, and we are. We're not biased to any organisation. We're hosted by the Christie. We don't work for the Christie. We're working on behalf of all you guys in the system. And I think it's really important to bring managers and clinicians together to make those decisions, to make improvements. But what's critical is the patient's voice. I've never had cancer. My husband has, but I've never had cancer. I don't know what it feels to wake up as a cancer patient and walk in the shoes of a cancer patient. So I can't tell a cancer patient how they should feel about getting access to cancer services and going through cancer diagnosis. So it's so important that we listen to our cancer patients about how we shape what we do. At the Cancer Alliance, we have significant numbers of patients who work across our pathways, skin included, but across all our pathways, who tell us how to make improvements to cancer services. And I think what's important is they've told us, no, you can't do it like that. We would like it like this. And it's really important to listen to our patients. You all know that. So our aims I've talked about is about early diagnosis and improving survival. That's standard, and we know we need to do that. More and more people are getting diagnosed with cancer, and I no doubt everybody in the room, my husband was in his middle 40s when he got diagnosed with cancer. It isn't, to me, a perception that it's a disease of the old, because lots of young people are getting cancer that they probably shouldn't be getting, and we're fearful of that. And we all know somebody who's very young who's had cancer, so we can't just do a broad brush that it's a disease of the older population, because it isn't. And we know we need to make strides across our pathways as a result of that. Reducing health inequalities is key. So Greater Manchester is 52 out of 54, which I can't remember what the number is, most deprived areas in the UK. So we've got high levels of deprivation, which you all know, and that means those populations within Greater Manchester may not get access to the best care, either because they don't know how or they don't have the financial support to get in and access our cancer services. So the health inequality is a big part of our cancer programme, and we're leading a whole programme of work about how we tackle health inequalities. We want to speed up cancer pathways. 62 days, I don't know if you've ever known how long 62 days is, a really long time. We make our patients wait to be seen and diagnosed and start the treatment. And we know the King didn't wait that long for obvious reasons, but most of our patients aren't privileged enough to get treated very quickly. So speeding up the pathway is absolutely critical. It's a big driving force behind the work that we do. And the person-centred care is critical. As I've talked about, we can't say that skin cancer treatment is for everybody over 70. We need to personalise it to that patient and their needs. If they're a dad or they're, or if they're, working in a full-time job, we need to be able to equate how we treat that patient based on their own personal needs. We have a plan on a page. So a Cancer Alliance, it tells you exactly what we're doing on one page. We quite like this plan on the page. It describes all the work we're doing. And if you need to know what's the detail behind that plan, it's there for you to have a look at, and we'll share these slides. And when we talk about delivery of cancer care, this is across the whole pathway, and pivotal to this is research. Pivotal to this is our workforce. We want to tackle SACT. We want to tackle some of the big issues that we've got in acute oncology across our system. So we're underpinning everything that involves cancer, but there is key domains in that. And this reflects all the work that we're going to be leading on in the next few years, and indeed the work that we've been doing for a few years prior to this. The Cancer Alliance has been going since 2016. So who are we accountable for? Well, the team all know that who work for me at the Cancer Alliance, we're judged on what we deliver. We're judged on the change that you see and the change that our patients see. But we are accountable, and there's a big slide there around our governance structure. You need to know that we are spending our money the way you would want us to spend it. We are measuring our risks and making sure that we're holding the system accountable for those risks. And we feed in through the mechanisms through the ICB and also to NHS England. We're very fortunate as a Cancer Alliance that we do a lot of brilliant work here in Greater Manchester that our other Cancer Alliance colleagues have took up, and we share that with all our colleagues across the system here. So, as I've said, it's really important today. We know how many cancer patients are sat waiting to start treatment, be diagnosed. We want to make sure that cancer is prioritised, and that's why we all get out of our bed in the morning. That's not to say we need to prioritise ourselves over anything else, but we need to make sure that we're fighting the corner for cancer, and that's our role and the role of my team at the Cancer Alliance, to make sure that elective care and other things don't usurp the importance of getting cancer patients seen and diagnosed. Innovation is absolutely critical, and one of the big things about the work that we do at the Cancer Alliance is about listening to our clinicians to innovate. And some of the innovations that our clinicians have done over the last few years have been unbelievable, whether it's the targeted lung health check programme, our prehab programme. A lot of our work in primary care education has changed the dial on how we are teaching and educating and transforming our cancer care, and some of it didn't cost a lot of money. And I think in times when we haven't got a lot of money here in the system, that's really critical. I've talked about the patient voice, and that is not tokenism. That is making sure that our patients are pivotal to everything that we do. At the Cancer Alliance, we have patients on our boards. They're in all our interviews. They're in all our meetings. There's no demarcation between what we talk to our patients about and what we talk to our clinical colleagues and our managers. So their voice is really critical. And I think what's important about what we've done as a Cancer Alliance is we've brought people together. That's collaborating not just in secondary care, but across the sectors, including our voluntary services and our local government. So we're working across the whole system. And I think, as I've alluded to, the important thing is about empowering you guys to change. So today, if you think there's things that are wrong within your services and that we can help as a Cancer Alliance, it's really important we have those conversations, that we help you fix some of the problems that are in your skin services. We've done loads already in skin, and the team have done a phenomenal job as the pathway boards leading this to transform with you guys. My nephew's just sent me, he's in Australia at the moment. He sent me a very sunny picture this morning saying, I put my sunscreen on because he knew I was coming here today, and it's like 39 degrees, it's really sunny, and I said, it's cold, it's minus whatever, bar humbug. But our sun safe campaigns and the campaigns, I know we don't feel like we see a lot of sun in Manchester, do we? But I was at the Tatton event with the team last year, the Tatton Flower Show. I've never been. It's very posh, it's very nice. And the demographic of that is the people who get skin cancer, and most of the people who walked past our stall had no sun cream on because it was cloudy that day. And we were educating them all about putting sunscreen on when you need to. So there's lots of campaigns that we're doing, and that's one of the things that we've done with our comms team. And it's really important about getting that messaging about early, about prevention and signs and symptoms. The team have been doing a brilliant work on Telederm. And I know that we were slow to get started on some of this in Greater Manchester, but there's been some amazing work done on that, and we know that some of our other areas are excelling across the UK in Telederm, and we're coming back up to meet some of the national requirements for that. So great piece of work been done on that. I've talked about education and in primary care, and I think it's really important that that work continues. This is not just about a GP going on a module once a month and thinking they've ticked the box for skin cancer education. This is long-term education programmes for our primary care colleagues to support them, to help them make the right decisions around that patient that's in front of them and the need for a referral. And we've also done some work, which many in the room will know, around dementia pathways for skin patients. And that's critical. That's where we want to make sure that it's access for everybody. And most importantly, I said at a meeting with Elaine and a few others last week that we can't grow skin cancer consultants, we can't grow specialist nurses on trees. We need to develop workforce models that make it robust. And we're doing a lot of work. Our workforce and education team at the Cancer Alliance have done phenomenal work to look at alternative workforce models, not just in skin, but across our pathways as well. So in summary, if you leave today and you didn't know what a Cancer Alliance is, we're working on behalf of you to make improvements to have really high quality care for everybody, high quality cancer care for everybody across Greater Manchester, and that's really important. We've put clinicians at the heart of our decision making, so it's not about managers and chief execs. We want to listen to you guys in the room about how we can make improvements to our cancer services across Greater Manchester. We're providing that leadership and support for you. We get funding, we can do things differently as a Cancer Alliance, as opposed to those of you in provider land. It's very difficult to get things off the ground, and we want to support that whole system change. And we do engage with all our stakeholders across the system, and then we do something well in Greater Manchester, and I think we're really good. It's the first skin event today, and we're always quite dynamic at getting things and being first at anything, but when we do something well, we don't just go, we're really good here in Greater Manchester. We do want to share, and we share a lot of the great work that we do as a Cancer Alliance with the system. So that's my preamble. If you want to get involved or contact any of us here at the Cancer Alliance, Jane, who leads the pathway forward and is absolutely brilliant. I don't know if you all know Jane, you will do, but she's phenomenal, hand going up there. An amazing lady. There's her email, but we also have a website which you can get all our information off. So I'll leave that one there, if that's okay. And just come on to our next event. So, and if I can just ask, if you come up and present, if you can then just sit down on the chairs, and then we're going to have our panel discussion afterwards. So it's our lovely Elaine up next. Welcome, Elaine.
Morning, everyone. Can you hear me okay? Yeah. So I'm just about to be joined by... No, it's not my backing singer. I cannot sing. So just being joined by two colleagues. Firstly, Dr. Aggie York. So Aggie is a GP, and she's also our clinical lead for the primary care element of our dermatology transformation programme. And Alison Jones, who's the Director of Commissioning and Early Diagnosis for the Cancer Alliance. I'm Elaine Hodkinson. I'm Programme Director currently for the GM Transformation Programme. So we're here today to give you an update about the work that we're doing, and between the three of us, we will all spend a few minutes just describing our work that we've been doing together. The Cancer Alliance plays such a huge part in the whole programme. So from my point of view, I don't think I need to tell any of you why we're here. There are many drivers that are contributing to the challenges that we face across the delivery of dermatology as a whole. We've got roughly about, if you think about the whole pathway, the cancer element being part of that, but we've got in excess of 27,000 patients currently on our waiting list at this point in time. As a GM system, at a senior level, it's been recognised that we actually need to put some investment into looking at how we might transform our services, and this programme came about to help with that. So we've been in place for just over a year and a half, and we originally set out with a 12-month time frame. That has been extended. What you can see on the slide there is our governance infrastructure. So we've developed a GM dermatology board, programme board. Into that, I'm pleased to see many people in the room that are part of this programme. So you've got colleagues around you today that will be able to tell you more about it if we don't cover everything off for you. We have a clinical advisory group, and we have a number of delivery groups, task and finish groups. We then report into what's called the GM Sustainable Services Programme. So that's a GM level board, which in turn reports to the ICB, as Claire referenced earlier. In terms of what we've been doing, we had a workshop back in April, a stakeholder workshop, and like a lot of the work of the Cancer Alliance, this is clinically led as well. So at that workshop, what we looked at is where do we focus our efforts and our time, because as I say, there are so many things that we could concentrate on. So what we agreed was that the front end of the pathway was where we wanted to focus our initial efforts, and on the right-hand side of the slide there, you can see the core principles of what we are aiming to do as part of that. So we recognise that we've got a lot of patients that are referred into our system on pathways, and many of those patients wait a very long time to be seen. So our core principles are optimal management of the patient in primary care, so where possible for the patient to remain in primary care, because that's sometimes the appropriate thing to do. Where the patient needs to come into another part of the service provision, then we're looking at patients being treated optimally before that happens. We're looking towards a single point of access across GM, so that those inequities of access that we talked about, the difference in waiting times, we will try to address as part of that. And incorporated into that will be specialist advice and where it's clinically indicated, teledermatology. Triage will then stream the patient to the most appropriate part of the system, so we recognise that's not always secondary care, and I know from talking to our secondary care colleagues and the information we've looked at that there are many patients in a secondary care remit on a secondary care waiting list that actually could be seen in somewhere in another part of the system by an appropriate colleague, and we've got many colleagues around GM who could support with that. And the final element is to strengthen our community offering, so what do we offer where, and how do our patients access our services in a way that meets their needs. So I'm going to hand over to Aggie firstly to talk about benefits.
Oh, thanks very much. So I'm a GP. I am very fortunate in that as part of my GP training, I did a 6-month stint in the world of dermatology, and that's how I kind of got a passion for it. And I suppose the challenge that we have as GPs is that there's known knowns and there's known unknowns, really. And dermatology is quite a unique specialty in that if you don't know what you are looking at, you don't know what it is. There's an algorithm you can follow in terms of if it's something that is concerning or something that's a risk in terms of cancers, etc. But ultimately, if you don't recognise what you are looking at, you're going to have to ask somebody else what it is, and that is very different to a lot of the other presenting complaints we get within primary care. If somebody walks in through the door with chest pain, there's a series of things we can do to eliminate the serious things and to reassure the patient that it's something that's completely benign and normal. In dermatology, if you've got a lesion that's sat in front of you, if you don't know what it is, that you've got to think of some kind of process to work out whether they need a referral or not. What we have seen, particularly with regards to the lockdown, etc., is the way that primary care has changed its ability to triage and stream and to meet demand. We still really struggle to meet demand, and a lot of things that were brought about within the pandemic were good, such as remote consultations, video consultations, etc. But also this kind of photograph first method of patients sending in their dermatology queries. And it's kind of changed the way that primary care functions. So we've gone from that model where a patient comes in, tells you the history, and then shows them what they're concerned about, to all of a sudden a clinician being presented with a photograph without any background. And it's a lot of what we're doing within the project has been to look at GP education to take you back to basics of history taking, because that's where 80% of your diagnosis lies, and then actually looking at lesions. What we did find is that because a lot of the GPs were unsure about what they were looking at, that they were being, the patients were being referred on the most timely pathway, which is a 2-week wait referral. And what we want to try and do, obviously, is get things back to basics, make sure that the triage is done, make sure that we are reinventing the way that primary care looks at dermatology, and that will ultimately be good for the patient. So we know that the 2-week wait times were absolutely massive, and a lot of the patients that are winding up in those clinics didn't need to be there. We've seen things like inflammatory dermatosis ending up in 2-week wait clinics, which isn't appropriate. And those patients who do have an inflammatory dermatosis, so your eczemas, your psoriasis, your severe acne, are having to wait long times because the secondary care clinicians are absolutely chock-a-block with the 2-week wait clinics. So we need to kind of get the system all realigned and more streamlined so that those patients who need to see secondary care can get there in a timely fashion. So, I mean, look at the programme benefits. We obviously know that the patient needs to be referred on the most appropriate pathways. They need to be seen in a timely manner, and also that they can be managed within primary care. And that doesn't necessarily mean with their own GP. It might mean going to a community clinic. We have a lot of skills out there in the community that aren't currently being utilised, probably because of a financial envelope, probably because people don't know what skills there are out there, and there's no clinic. So we want to really strengthen that community offer. From the referrer's point of view, so me as a GP, I will be incredibly reassured if I've got something that's not a 2-week wait, but not a routine and an urgent, if I can get that patient seen within 6 weeks, something like that. Because I think at the moment, because there isn't that global offer across GM, the GPs, they don't want that patient to wait 104 weeks, so they're sending everything on a 2-week wait because they're scared of the patient coming to harm. And that patient's then presenting time and time again. So obviously from a referrer's point of view, we know our patients are going to be more satisfied, they're going to get to the right place at the right time, first time round, hopefully. And it will also stop people from bouncing back to primary care every month with another appointment saying, I'm still no better, I'm still no better. We also know that the kind of innovation of teledermatology will be really useful if it's clinically indicated, and we want to be able to use that appropriately to know when it is appropriate to get that advice and guidance. And obviously the advantages from the provider point of view is they're going to see people who actually need to be there in their clinics, and they want to see the patients that they can actually help, and leave the patients who can be seen in the community to us out here in primary care. And I suppose the other thing is in terms of the triage, the resources are going to be appropriately used, and we're going to be able to allow transparency, and we're going to be able to respond to the system depending on where the needs and the demands are, and test and review pilots that are ongoing, etc. And it'll all be very streamlined, and hopefully, like I say, there's going to be no postcode lottery. Everybody's going to have equitable access into the dermatology services. So I'll hand over to Ali. There you go. Yeah, do we have to like? There you go.
Yep. So you've heard already from Claire about the work of the Cancer Alliance and the main programmes of work that the Cancer Alliance are responsible for. And then you've heard from Elaine and Aggie how that GM dermatology programme works. And Elaine emphasised the importance of that joint work across the GM dermatology programme and the Cancer Alliance. So what I just wanted to quickly illustrate was the ways in which we're doing that, and the ways in which the work of the GM dermatology programme board and the whole structure that supports that actually supports some of our work as a Cancer Alliance and vice versa. So the GP and primary care education bit is a really fundamental part of that. So as both Aggie and Elaine have said, we're doing a huge amount of work on education for GP and primary care colleagues. And that is slightly different for this pathway than maybe for some of the other pathways. So we do a lot of work around early diagnosis with the other pathways, encouraging people to come forward, signs and symptoms, refer appropriately, loads of education on that. Slightly different for skin in that we do that, but we're also doing quite a significant amount of work on what to not refer. So that feels a little bit different. So we don't necessarily say that with some of the other pathways, but there are some very strong messages that we're trying to get across to support some of what Aggie's just described, so that GPs feel confident not referring certain things and that they understand the appropriate way to manage particular conditions. So I think that's probably a little bit of an anomaly with the GP and primary care education as opposed to some of the other programmes that we're leading. Teledermatology, that's had a mention already from everybody who's spoken, so I won't labour that point, but loads of work being done, and we've got Kerry in the room as well who's supporting a lot of that work from a Cancer Alliance perspective. We've got a clinical decision support tool in place across the whole of Greater Manchester. It was something that the NHS Cancer Programme included as a requirement in previous planning guidance that Cancer Alliances had to provide, build, establish a clinical decision support tool. So that basically helps GPs with that decision making. It provides access in a single place to information to support suspected cancer referrals. Again, with this pathway, we've done something slightly different. So we're working really closely with Elaine and the team on expanding what that decision support tool looks like in primary care. So it's on all GP systems in GM. So it sits as part of the GP system. It's not something that GPs have to think, oh, I'll go and log on to that and have a look what it says. It's automatically built in to the GP systems. So we're doing a great amount of work with Elaine on not just looking at cancer, but actually looking at how we might be able to expand that decision support tool to non-cancer pathways from a skin perspective. So again, something that's slightly different for this pathway. Claire made reference earlier to the funding that the Cancer Alliance receive every year. So we have been fortunate enough to allocate some of that funding to support some of the work that you've heard about already and that you'll probably hear about through the rest of the day. So some of that resource that we've been able to provide, additional capacity. So we've got the issue around the waiting times and the diagnostics and the treatment and the number of people that are on a pathway and on waiting lists. So we've worked to try and provide some additional funding for capacity for that. We funded some of the GP training and some of that support for Elaine's team as well, so that we're genuinely doing this in a joint way. This is a little while ago, but we did provide some funding for dermatoscopes for colleagues in primary care to use. And what we're doing through the training that we continue to deliver via the Academy and via the Decide training that Elaine set up and also through Gateway C is to really encourage GPs to use those to inform their own decisions. So whether an image goes with a referral or not, we're saying to GPs, please use this equipment where you've got it and where you feel capable to use it, and use it to help your own decision making in thinking, what do I do with this patient now? So the whole process that Aggie's just described, what we're trying to do is encourage GPs to use the equipment that they've got and to use that to best effect. And then I would get a dirty look from the back of the room and not spoken to for the rest of the day if I didn't mention the importance of the cancer waiting time standards and the whole operational performance and delivery. And I know Claire made reference to that earlier as well. So obviously the Cancer Alliance have a significant role in working alongside colleagues in the dermatology programme to make sure whatever the pathways are that are developed and whatever the solutions are that are being looked at, they are in line with the cancer waiting time standards, but also that they help to deliver those improvements. The picture on the right, these are just some examples of some of the training that we've done for GPs. So Steph has featured heavily in these. I didn't make yours the biggest picture because I thought you might shout at me, but we can provide the links for these, but we've done some brilliant webinars with the support of Gateway C, and we continue to promote those. I think the value of having this kind of resource, and there's one of the paper copies of these on the board over on the other side of the room, the real value of having this is it's a resource that we can continue to share. And then working with Molly and Tilly and the rest of the team, we can do that jointly and use the access and the contacts that the Cancer Academy are developing to share the information that we've got. So it's something that's there already. We don't need to keep redoing it. We update it as necessary, but it's a resource that we can continue to share. I'll leave it there. Thank you.
Oh, come on then. Oh, Ali's got a call to do. Yeah, that's right. Yeah. We'll let her off. We'll let you off, Ali. Please save your questions, write them down, or my menopausal broken brain, I won't remember the questions. So if there's anything you want to ask the panel, we'll save everybody to sit down, and then we'll have a little bit of a panel discussion then, if that's okay. So next on the hock is our lovely Molly. He's going to talk about lifelong learning in cancer. It's all right for you to say, because you're young. Come on, Mel.
Thanks, Claire. So lovely to be here today, and thank you, Jane and Steph, for inviting me to speak. It's great to see so many of you in the room, as Claire said, for the first event that we've done under the Skin Academy. I'm Molly Pipping. I'm the Senior Programme Lead for Education at the Cancer Alliance, and I have the pleasure of leading our academy. So I'm hoping that because you're here, most of you know what we do, but just to make sure that it's a level playing field, we were established in 2022 to support the development of that sustainable lifelong learning model, predominantly for our non-medical workforce. And this is all about making sure that we can meet the current and future needs of our population. So the Academy, we provide learning across all care settings, and it's about making sure that we're equipping our workforce with the skills and tools necessary to deliver that best patient care. As I'm sure you can imagine, everything that we do supports the NHS People Plan and the long-term ambitions for cancer care. And I think one of the beauties of having an academy is that it really supports everything that Claire talked about at the beginning around that inequality spin. It helps reduce that inequity around access to cancer education and supports that standardisation of offer, so we take away that postcode lottery element. And I think that something that's quite unique to us is that everything that we do is driven by our workforce need. So we do a lot of scoping exercises and speaking to our workforce, people on the shop floor, around what they need to know in practice. So, as I said, we're established in 2022, and we went through this modelling phase in terms of what does a cancer academy look like? Is it a place? Is it a thing? What is it? So you can see on the right-hand side there what our website is, and you're all in the room today, so I'm guessing you've all visited it to book a place. So this is our hive of cancer education, where you can find our offers and where we also signpost out to all of the other great work that's going on. As Ali mentioned, the work that happens with Gateway C, the offers that the School of Oncology have, and also other national providers as well. But we create our own learning in-house. We take that blended learning approach, whether that's a module, a webinar, a skills lab where people can come and get hands-on practical skills, events like today, and also podcasts. We have an education directory, which is just going through a bit of a remodel at the moment, but that's the signposting out mechanism to the other fantastic work that's going on. And we also have an e-portfolio, which I will come on to in some more detail shortly. But we spent a lot of time in this pilot period within urology services trying to figure out what this model looked like. But we went through a vast period of expansion, and now we've got 20 different academies, all tumour site specific, subspecialty driven, and you can find all of the information for those on the website. So the Cancer Academy sits within the Workforce and Education Programme of Work at the Cancer Alliance. So these are some of the pillars that sit within that strategy that the Academy is really an enabler for in terms of that delivery. And my poor team, when I produced this blueprint, showing them what we would deliver this financial year, I think they all were a little bit panicked, but pleased to say that we've actually delivered the majority of the stuff that's on this plan. So you can really see the plethora of work that we do, and there's a lot of information at the bottom there that demonstrates the cross-cutting work that takes place as well, whether that's in personalised care, early diagnosis, health inequalities, so on and so forth. So in terms of skin, we've been working with Jane and Steph to look at what our programme of work can look like for next year. And there's loads of stuff that I think that we need to flesh out a little bit further. But one of the conversations that I would really like to pick up, I think, off the back of today and the conversation in the room is around that telederm piece. I think there's a lot that we can do. We were looking at doing skills labs in this space. And I think it would be a fantastic space to build on. But we will be doing more primary care education, as Ali said, next year, and hopefully some other areas to explore as well. So just wanted to shed light on some of the current offers that we've got that aren't necessarily specific to skin, but are relevant to every single person who sits in this room, and think that we've really started to develop our communication skills offering as a Cancer Alliance. So flyer here says it all. We understand that good communication underpins best patient care and positive team dynamics. So we started off this piece of work by working in conjunction with the LGBT Foundation, and we've created a module around having more inclusive conversations and using empowering terminology when you're in your clinics or when you sat there with a patient, or even having a conversation with one of your peers, one of your team. This is free to access, it's all CPD accredited, and I'd really encourage anyone to go and look at this resource. I think it's fantastic, and it's got some case studies that are specific to cancer within there as well. We've then gone one step further, and really excited to share this actually. We talked about innovation, and I think it's something that is really key in terms of driving that change. And this might be a little bit disruptive and we don't know if it will pay off, but I think it's really important that we trial these new ways of working. So we know that we need to recruit, I think it's 30,000 more CNSs before 2030 to make sure that we're meeting demand, and obviously that's a national figure. But every single CNS needs advanced communication skills training, and that's 2 days of training, and it's very costly. And I'm not saying that people don't need that training, but actually that's a lot of time, that's a lot of money and investment. So what can we do to approach that differently? And it's not just our CNSs who need the skills, it's our AHPs, it's our GPs, it's our student nurses who are coming through. So we've developed this AI-driven offer, which is around experiential learning, where our workforce can practice breaking bad news and de-escalating situations in a controlled, safe environment. It is a pilot, so I'll caveat that. We don't know how it will work yet, but we've got 200 people going through this pilot. It launched yesterday, over a 6-month course, and then we will evaluate the findings. But NHS England are quite interested in this one, so watch this space, and there are still some places available. So if there's anyone in the room who is interested, then please go and find one of my team in one of the breaks and give them your email address, and we can give you a spot on this so you can trial it over the next 6 months. I suppose for anyone in the room as well who works in secondary care, just to build on this, if you need your psychological level 2 training, then we do have that hybrid offer that we offer through the Cancer Academy as well. So again, please chat to the team because there are some dates available for this coming year. I couldn't do this presentation without talking about Ascend, and I'm hopeful that most people in the room will have heard about this by now. It's been around for a while, but for anyone who doesn't, Ascend is the Aspirant Cancer Career and Education Development Programme. This is an end-to-end career framework that's come out of NHS England that is all about making sure that we can really grow our own and support the retention of our staff. And I've got a bit of a video, which I'm hoping will work, that explains the next part a little bit better than I can, and then we can build on that.
Introducing the new Greater Manchester Cancer Academy e-portfolio platform. A brand new system designed to support you with your professional development. With the e-portfolio, you'll now be able to log your learning achievements and highlight development opportunities to progress with your career. You'll also be able to have more informed appraisal conversations, as well as support with revalidation. The e-portfolio is centred around the levels of practice in the Ascend framework: supportive, assistive, pre-registration, registration, enhanced, advanced, and consultant. We've also created the speciality-specific frameworks for each cancer pathway. So whatever level you're currently at, you'll have the resources you need to progress in the palm of your hand. Find out more and create your e-portfolio at gmcanceracademy.org.uk.
So, as you've all registered for this event, you all have access to the e-portfolio, free at the point of access on the Cancer Academy website. Ascend is a really huge capability framework. I think there's 400 different capabilities in it, and it's not digitised anywhere yet. So this is the first place that you're able to see it and really integrate and use Ascend and implement it in your practice. As the video alluded to, we've got site-specific variations of the framework, and Gina, who's our practice educator, is about to start a variation education for skin. So if there is anyone in the room as well who would be interested in looking at specific capabilities that align to that framework that sit within the skin pathway, then please again have a chat with one of the team during the breaks, and we can make sure that we get in contact with you, because it's really important for us that that's fit for purpose for you as the end user and the people who will be using that. This is just a bit of a screenshot in terms of what it looks like when you log in, and you can add all of your learning on it. When you add an entry, we will have done a national mapping exercise as well in terms of all of the other great stuff that's out there, and we will have mapped it to the capabilities for you. But you can also add in your own reflections, for example, if you've observed something on award round that you'd like to include as part of that. And I just couldn't end my presentation without talking about another event that you should all come to. So our flagship Greater Manchester Cancer Conference is taking place in May. It's over 2 days with our awards evening in the middle. It's a fantastic event, and I think that the buzz that you get is just like, obviously today is fantastic. There's 80 people in the room. You're all like-minded working in the same space, but I think there's something really special about the conference when you have people across the whole of Greater Manchester from different specialties and different levels of practice all coming together for the same reason and just sharing knowledge across different spaces. So please come along, book your tickets. Again, you can do that on the Academy website. They are limited, even though there's 600 people a day. So if you're interested, they go and grab one. And if you are doing a bit of a transformation project, or you've done something service improvement-wise that you're really proud of, then the deadline for award submissions is the 16th of February. So you've got a little bit longer to submit those. And we're also open to poster entries as well. So if you've done one today, then resubmit it for the conference. I can't stay for the questions either, because I'm going to go and shoot off and do some interviews. But the team's social media accounts are on here. And again, I'm sure if anyone has any questions, you can grab one of my lovely team who will be behind the desk later. Thanks, Claire.
How amazing is Molly and her team? And we know not every organisation has signed up to Ascend. I'm not sure everybody, every nurse, every AHP, all of you clinicians in the room know about the great work this e-portfolio does and the great work of the Cancer Academy. We've done all of this free at point of whatever. And it's really, really important that you know that this resource is here. And then the conference, please come, because it's amazing. And if you're doing really good work, put yourself forward for the awards as well. There's loads of different categories, and you can go on the website. It's slightly like organising a wedding, so I'm sweating at the thought that it's only in May and we've all got to organise this big conference of 500 people and blah, blah, and last year, last time we did it, people got wiped out on the day with COVID and all sorts, so it's slightly tense time. But it's a really brilliant, fun event, so please do come along and sign up for that. And she's right, that we're limited on numbers and tickets. So we're going to just end this session with our lovely Steph, who's just going to give a summary of everything that's going on and the future for skin services across, keep saying cancer, not skin services across Greater Manchester. And then we'll have a little Q&A session here. Okay, thanks, Steph.
Hi everyone. I know a lot of people in the room, but if you don't know me, I'm Stephanie Ogden, a dermatology consultant at the Northern Care Alliance. And I'm talking about the future of skin cancer services in GM and across Mid and East Cheshire. So I was just going to really brief you on the current issues. I'm sure most of you are familiar with the current issues that we've got with skin cancer services and the variability in patient waiting times and access. And then look at some of our plans for the future and things that we've started to do already to try and improve things for our cancer patients. So the current position. So this just really outlines our network in Greater Manchester, the different areas and the different localities, and then we've got our Cheshire section as well, and it just shows actually who's providing the services locally. And you can see the NCA provide a large proportion of skin cancer services across Greater Manchester, covering the Salford, the Bury and the Stockport sites, and also some of what was HMR. And then MFT also providing a significant proportion of the services. And then we've got some excellent small smaller groups represented here today, for example, Bolton, Wigan, Tameside currently having some issues, so being supported by some of our other teams as well. But it just gives you a bit of an idea of the sorts of numbers of patients as well that we're tracking on skin cancer pathways, and you can see there's thousands of patients going through our services. So looking at the current position, the current standards, so I'm sure all of you are familiar with the faster diagnostic standard, which really is one of the key focus. We used to, as you know, have the 14-day, 2-week wait standard, but we're moving away from that now to focusing on when a patient gets their diagnosis of either not or having a cancer, and really try and speed up that pathway. So the 28-day standard is a big focus. So we want to have 75% of patients at least receiving either a diagnosis or an all clear by day 28 from GP referral. And of course, that's fine if on the day or you see the image and it's a benign lesion, but when we need pathology, then that becomes a lot more difficult and challenging for us to get patients into theatre, and then our pathology team, who are left with a very short turnaround time under a lot of pressure to try and get those results out for us. The 31-day standard, again, so for patients getting their treatment, the 62-day standard is from the referral from the GP to getting their first definitive treatment as well. So this is just an overview of figures that are a little bit out of date now, and in fact our position has improved quite significantly since then, so that is something positive. But not to focus on every last number, but this is looking at the proportion of patients seen within 2 weeks from referral for suspected skin cancer. And looking towards the end of last year, and even though the 2-week wait standard is gone, we do still look at that because it is important for patients to get that first appointment early, because if they need tests, then, you know, time's ticking on. And you can see really we're just below 50% of patients achieving that, which is well below what was the old target there. And that makes it very difficult then to achieve your FDS for patients that are needing investigations. And this here is the same data, but just giving you the idea of the sheer numbers of patients that are coming through our services. So thousands of patients each month. And then looking at the FDS target, unfortunately, we're not quite there overall recently, but again, our figures are improving, and a lot of it is dependent on how we're doing at the NCA and MFT, because we're such big providers of services. So although some of our smaller providers are doing really well with their figures, we're dragging them down at the large services there. So it's really important that we work as a whole team, as a whole group, to provide an equitable service across Greater Manchester. And then, so this is 31 days to first treatment from referral. The 31-day target there set quite high at 96%. And you can see, again, unfortunately, we're not reaching that target recently. And then the 62-day target, really important for patients as well. If you think, as Claire was saying, 62 days is a long time from when you've been referred from your GP to getting your treatment, and we weren't quite there at 66.67% when the target is 85%. And this is just showing us the cancer conversion rates across the trust. So what proportion of those patients that are coming into us actually have a trackable cancer diagnosis, so melanoma, squamous cell carcinoma, and it's pretty low overall at 7%. So that's not dissimilar to national figures, actually. So it's not like we're really lagging behind, but you can see that sheer number of benign lesions that we're screening out, and that's a lot of the work that we've been doing and a lot of our focus for the future in the Cancer Alliance, and what Aggie and Elaine and the team were touching on, to try and improve that conversion rate, and then those patients with the benign lesions can be managed safely and more quickly in primary care. And this is just to highlight as well, this is just some of our own data from the NCA, just to show you that upward trend in referrals that's been happening year on year Of course, COVID had a bit of an impact, but if you look at the light blue figures from last year, you can see that massive increase in referrals coming through, and that is what we're trying to work on, because this continued increase in patients coming through the 2-week wait pathway, as Aggie has touched on, is really impacting our ability to manage patients who've got inflammatory skin disease, and it's sort of a bit of a vicious circle really, because GPs can't get patients in any other way than on the 2-week wait pathway. And this is just to highlight some work that Dan and Holly, our registrars, did looking at recent 2-week wait referrals coming through the NCA. So our Stockport, Bury and Salford sites, 100 from each. And just to show you, I mean, again, we all know this from doing clinics, but that high proportion of benign diagnosis, the seborrheic keratosis being the number one. So about 20% of our referrals on the 2-week wait pathway being seborrheic keratoses. A lot of actinic keratoses coming through as well. So getting this sort of data is what's helping us focus our education and our plans for the future. And you can see here the relatively smaller proportion of skin cancers that are coming through. But if we could really start to pick out those patients with those easier benign or non-skin cancer diagnoses, and to support our colleagues in primary care to manage those more effectively for the future, then obviously that will have a huge impact for us, because it's huge numbers of patients. When you see it's thousands every month, if those patients weren't coming through to us on the 2-week wait pathway, we'd really have a lot of opportunity to offer other services. So based on that, and already touched on by colleagues, so education for the future. So the DECIDE model, many of you will be familiar with. So Professor Minnie Singh, one of our dermatology colleagues and a professor of medical education, developed a programme of education for primary care colleagues, which is evidence-based. It showed an improvement in referral practices and diagnoses for the GPs that had undertaken the training. So it is very much based on taking the full history, getting that information, the examination, and then obviously for lesions, the use of dermoscopy as well. So we've provided an initial lecture-based programme. We had patients, we had GPs in the room and online, and then that is now available for any GP or primary care colleague to access whenever they want through the GMCA website. And then following on from that, to cement the learning, inpatient workshops. So with patient workshops, I should say. So we've got patients coming in and primary care colleagues going around seeing the patients with support from secondary care experts and getting to use their dermatoscope, put that learning into practice to really cement the learning, give them the confidence to examine the lesions with a dermatoscope, and then hopefully then that'll go out into the community and just give GPs more confidence. So that's a plan sort of to continue on for the future, really, and hopefully we'll see the benefit of that over time. The dynamic referral template as well, Elaine and Aggie touched on this earlier, and Ali. So this is a clinical decision tool in primary care to support our GPs. So an example that we sort of worked off really was the breast pathway, where a lot of patients were being referred in with mastalgia, which I'm told is not a common symptom associated with breast cancer. In fact, you're very unlikely to have breast cancer if you present with mastalgia. So they actually embedded that into the 2-week wait referral. So if the GP types in mastalgia, then it takes them onto a different pathway and provides them with the learning and information that they need. So we thought, well, can we use that for skin actually to help us and help our primary care colleagues? So we're developing this template, be one for lesions, and then hopefully bring in inflammatory dermatoses, which includes that history taking and diagnosis, and then linked to supportive resources such as dermoscopy or what a seborrheic keratosis looks like. And we're working with the Primary Care Dermatology Society on that to use some of the algorithms that they already have in practice. But it will be embedded into the GP referral system, as the team was saying, so it's not an option. So it does really help, you know, if you have to tick the box to say, well, have you done this first or have you done that? And then it just really supportive as well. We've touched on also the future workforce. There's a big shortage of everybody in the NHS. we've had a really successful experience with our physician associate David, who's here today at the Northern Care Alliance, and we've shared that with colleagues through the Skin Cancer Pathway Board, and he's been a great asset to our service, and we're happy to share that learning as well with other teams, as we've done so already. We've got some great GP with extended roles, again in the room today. Hi, James. And a fantastic specialist nurse team, many of whom today. So we're so fortunate to have all these people working with us. But there is potential for more, to expand our workforce and work in different ways to try and provide all that care for our patients coming in. Teledermatology, it's coming and it's expanding whether we like it or not. So it was in last year's planning guidance from NHS England, so it's not an option, that we are mandated to do this. So the data that they wanted from us was the percentage of urgent cancer referrals for suspected skin cancer meeting the faster diagnostic standards, so that's performance. But then they also really wanted to look at the percentage of suspected skin cancer managed through teledermatology with audits of the numbers at the end of Q1 and Q3. That's only going to get more for the 24-25 planning guidance as well, which I don't think it's been fully released, has it yet? But it's been hinted at, shall we say. So we're very fortunate to have Kerry working with us now at the Cancer Alliance and with the GM Dermatology Group, who is leading teledermatology, so linking all the different areas across Greater Manchester. And she'll be mapping out what current offering, well, she already has actually mapped out the current offerings across Greater Manchester, established consistent reporting tools and methods of seeking feedback from patients of their experience of going through teledermatology services. And she's linking in both regionally and nationally with colleagues who've got more established services, for example, to understand challenges and successes with teledermatology that we can then incorporate into our own learning. AI, again, coming whether we like it or not. Projects planned locally at MFT and at HMR using Skin Analytics, who are working with NHS England. So Skin Analytics, I'm sure many of you have heard of the company. So they use AI to enable dermatology pathways within the NHS. So they have a cloud-based platform and AI algorithm which analyses dermoscopic images of skin lesions to support assessment and triage of suspected skin cancers. So the way that will work in the future, so in the Pennine Primary Care Network, they're looking at 2-week wait skin referrals, and they are looking at ensuring patients with a lesion go to the correct pathway. So that will be set up via the GPs, will be doing that aspect, whereas at the MFT pathway it's going to be in secondary care. So when the patient's already been referred in on the 2-week wait pathway, they'll go into that skin analytics. There'll be a picture, dermoscopic picture of their lesion, which will be analysed by the algorithm. If it's benign, they're discharged. If it's not, then they go into the secondary care system, or if it flags, as a concern. At the moment, there is a second check of those benign lesions by a dermatologist, but that is likely to be removed in the future. We've touched on as well trying to plan equitable access for our skin cancer patients across Greater Manchester. You can see when I was, the figures, there's quite a variation between the different trusts and providers across Greater Manchester for patients being seen and their pathways being closed within target. And we have previously discussed whether there could be a single queue for patients to access services across Greater Manchester. But it is a challenge, or will be a challenge for the future, because a lot of the providers are using different systems for their teledermatology, for example. So then if you've got one using ERS, for example, we're using eDerma at the Northern Care Alliance, and then Skin Analytics at MFT, for example. I know Mid-Cheshire use Synaptis, although that's not for 2-week wait referrals at the moment, I don't think. But, so everyone using a different system, and then it may make things a little bit more complicated in that respect. But it is something that we have thought about and considered. I think that's it, everyone.
So that's the end of our first session. So much stuff going on already, and we're not even at 10:30. So we've got probably a couple of minutes, 5 or 10 minutes, to have a quick panel discussion, and then we've got a coffee break where you can do your networking and mingling and have a few biscuits and cakes till 10:50. So hands up, anyone who's got a question for our esteemed panel here. Don't be shy, because I know you're not. Great.
Thank you very much. I had a comment and a question. So I think it's really interesting to hear all this work that's going on behind the scenes, because I think as a clinician in clinic, you can feel quite remote from a lot of this systems-based work that's going on, and the slides are very complicated and have small text, so I have a broad brushstroke rather than the detail. But my question was, in terms of the e-portfolio that you've now set up on the Academy website, do you have any kind of guarantee of timescale funding for that? Just because, if you invest time engaging with an educational portfolio, you don't want to know it's going to get shut down after the next 2 years or whatever.
It's going nowhere.
Right, fine,
so
thank you.
And Molly's not here, but I'll speak on behalf of Molly. This is lifelong, so it's going to be, we hope, embedded nationally across the UK. So if you move around and work wherever, that academy model will be across system. And forgive me if there's any of the team in the room who want to, Molly's team, who want to speak on this. But we are not just doing a short term. And I think one of the big things I want to say about the Cancer Alliance, we're not just piloting, a few things that we're piloting, like you've heard of some of the AI things. We want to embed things that are for future proofing. So that academy is going nowhere. We've invested a lot of time, effort to make that model work across all of our disease specialties, you'll see, not just in skin. So that's in for the long haul. So please invest your time, because it will pay dividends for you, for your career, for the future as well, if that's what you're looking at. And your modules to be a lifelong learner as well. Yeah. Any other questions?
Thank you very much. Sorry, I'm the cougher in the room. I really enjoyed all the talks, and I think it's really good to hear everything that's going on in GM about cancer. I'm a pathologist, and obviously pathology is integral to cancer diagnosis, and nobody mentioned it. So I just wonder, what is the Manchester Cancer Academy doing about pathology?
I don't know the specifics around pathology modules, and if it's not been mentioned, there's a whole section coming up about pathology.
I'm chairing it, and I don't know.
Oh, right. Well, good. The Cancer Academy is across all workforces, and there is a big review of how we do pathology in Greater Manchester, of which I'm working with Lisa and many others on here. I don't know if any others have. Lisa, do you want to come in?
So I was just going to say that pathology is absolutely essential, not just for the skin pathway, but for all of our tumour sites. And I think that we have to be really savvy on how we use that resource. So I think much of what is planned is around how we make the best use of the resources that we've got. I know that there are lots of examples in the recent work that we've done that show one sample might have been sufficient if we'd have done an excision rather than just biopsies. So much of that work is around the maximising the benefits and reducing unnecessary workload. And I think that that's linked into the design work of teledermatology, how we use teledermatology, making sure it's the right patient cohorts so that we don't add a complexity or a problem further down the line for any other team.
Just add a bit more, Claire.
Please, yeah.
Just in terms of the programme, so I've realised we didn't mention it this morning, but we recognise that pathology obviously plays a big part in this. So the connection point for that is with the pathology teams and the diagnostics and prescribing work. So we know that you're doing something locally, but we're also trying to make sure that that's aligned with the work we're doing and that we work together on it.
Super. Okay. We look forward to your session. And I'm loving your earrings, very glamorous. Okay, there must be another question in the room, surely. Jolly good. And I'm keen to know what our physicians associates, but I won't put them on the spot if they don't want to speak. Sorry, I'll come and ask you at the lunch break.
Yeah, thank you. I was just going to ask, obviously the Skin Academy that you've presented seems to be very dermatology-led, but there are obviously other providers that are very involved, such as plastic surgeons, maxillofacial surgeons, and ENT. So do they have any input into where things go? Because we do add a lot to what's happening with the cancer pathway and what have you.
So we have a lot of plastic surgery colleagues who come to the Skin Cancer Pathway Board, who are an integral part of the team. Pratap, for example, is here and he's speaking later, and input into design of services and all the plans that we have in terms of education and service developments and things like that. Is that what you mean, or did you mean in other things?
No, that's exactly what I meant, yeah.
Yeah, we do, and we're open to more keen members.
You've just nominated yourself to come and work on the Pathway Board. Well done. If you sat in the room and you're thinking you're left out of what we're doing and the work programme that's going on, please do come and speak to us, because we're representing everybody. And when I mentioned ward clerks and reception staff, we want the views of everybody to help improvements, whether it's in skin and all our cancers. And if you sat in clinic and you don't know what we're doing and aren't involved, please do get involved. And we have a dedicated Pathway Board. We have a lot of online resources that people can access and utilise, and it's really important because we also want you to use them to then go back and talk to your colleagues about particularly some of the education and training that's going on, but particularly the programmes of transformation that we're doing on such a large scale in a specialty that's overrun, and whether that's in pathology, whether that's in surgery, and across our services at the moment. So we've got to innovate our way out of the problems that we've got going forward, and we can do that, but we can't do that in isolation with panel members. We have to have you guys involved, and if you're in the room today and you want to get involved, please do come and speak to us. That's really important, that we represent everybody and you don't feel like you're not represented, or certainly don't know the work that's going on.
Yeah, and just follow on from that, we have our oncology colleagues as well, of course, an integral part of the Pathway Board, some of whom are here and are speaking today and have been involved in, for example, our Sun Awareness campaign, came to Tatton Park and things like that, and have been integral for creating the Melanoma Shared Care pathway, which hopefully will be published very shortly and we'll be able to roll out across Greater Manchester, and that's been driven by the melanoma oncology team with input from other members of the Pathway Board as well. So there's certainly work going on across the specialties involved in skin cancer. I know it does seem very dermatology focused because I'm perhaps a little biased, but...
Yeah.
Pratap?
Super.
Okay.
Hi, I would just like to add on to Steph's. Thanks, Zishan, for asking the question. So the inputs are multimodality, multidisciplinary, so everybody contributes through the Pathway Board, through the education team, who are doing a fantastic job. And also the learnings are different modules as well, so it's multidisciplinary as well. If you're a dermatologist, you can go into the module that is for it. If you're a pathologist, you can go into the module for it. If you are a plastic surgeon or ENT, you can go into the modules for it. As Claire said, it's for longer term. It's to build your confidence as well as learning, and more importantly, shared and working together to defeat cancer.
What a marvellous way to end. Thank you. And we didn't not paid you £10 to say that. That's well done. Super. So if there's no more questions, we've got a coffee break till 10:50. And then we've got our pathology lead coming to talk about that and a few other things later on this morning. So welcome you all back later. And most importantly, thanks to our panel members.